In this lesson, I will discuss the concepts of pulmonary hypertension and dilated cardiomyopathies. Let's start off by talking about the vascular pressure in pulmonary and systemic circulation. Here we have the heart, the right heart and the left heart. We can view the heart as a two-pump system. Low pressure pump, the right heart, high pressure pump, the left heart. Here we have the blood rich in CO2. This blood goes to the right heart. Eventually, it reaches the right ventricle. The right ventricle generates the pressure that exceeds the pressure in the pulmonary artery. Then the blood reaches the lungs, where CO2 is exhaled. Then we have blood rich in oxygen. This blood returns to the left heart. Eventually, it reaches the left ventricle. The left ventricle develops a high pressure, which exceeds the pressure in the aorta, so that the aortic valve opens up. Then the blood goes to the body everywhere. The right-sided heart, or the cardiopulmonary circulation, is a low-pressure system, also a low-resistance system. For this cardiopulmonary circulation to be a low-pressure and a low-resistance system, some requirements will have to be met, the most important of which is that the pulmonary artery has a high compliance. This means that it can be easily distended, does not offer a great resistance to flow. Now let's take a look at some pressure values in mercury units in the pulmonary artery, the right ventricle, and the left ventricle. Physiologically, the pressure inside the pulmonary artery is between 9 and 24. The mean value is around 14. You can see in the left ventricle, in systole, the pressure can go up to 120, much higher than in the cardiopulmonary circulation. If, for some reason, on the right side or the left side, the pressures go up significantly. On the right side, this results in cardiomyopathies, right-sided cardiomyopathies. On the left side, left-sided cardiomyopathies. We start with the right side, cor pulmonale, or right-sided heart failure. Cor pulmonale is the right heart failure caused by a primary pulmonary disorder, normally primary hypertension. Cor pulmonale causes the right ventricle to fail. So, different lung disorders may cause pulmonary hypertension. Now, pulmonary hypertension is quite complex. It can be classified into 5 different groups. I'll discuss them in follow-up videos. But for now, let's just assume, for some pathological reasons, we have pulmonary hypertension. So, now we have a much higher resistance and much higher pressure. The consequences for the right ventricle are as follows. The blood starts to back up in the right ventricle. The volume goes up, the pressure goes up. This increases the wall stress. Why? We can see here, as the volume inside the ventricle goes up, volume and pressure, this stretches the sarcomeres more and more. I discussed the sarcomeres in previous videos. We can see as we stretch the sarcomeres, we also increase the wall stress in the right ventricle. When we think about wall stress, we think about the law of Laplace, which states for a sphere, let's assume this is the structure of the right ventricle, simplified. We have here a sphere. T is wall stress, is equal to the pressure inside the ventricle compared to the outside. This is so-called as transmural pressure. T, the wall stress, is equal to the pressure times the radius of the ventricle. And the radius itself is determined, among others, by the volume inside the ventricle. Again, T, the wall stress, is equal to the pressure times the radius or volume divided by twice the wall thickness. Now, as the volume inside the right ventricle backs up, the volume inside the ventricle goes up, so does the pressure. We see that pressure and volume go up. This raises the wall stress significantly. An increase in wall stress means a much higher demand for oxygen and energy. This may lead eventually to right-sided heart failure. cardiac and cellular remodeling takes place. Now, based on the law of Laplace, let's see how these processes unfold. Here we have the normal state of the right ventricle. As the volume starts to back up in the right ventricle due to pulmonary hypertension, we can see here increase in volume and also increase in pressure. Volume and pressure go up, so the wall stress also goes up. Physiologically, we can counter this by increasing the wall thickness. You can see here the wall thickness goes up. This is done by parallel arrangement of sarcomeres, more and more sarcomeres in parallel. This increases the wall thickness. Increasing the wall thickness, reg, normalizes the wall stress. However, if this persists, this becomes pathological. The radius and the pressure keeps going up. Both of them, they keep going up. And the wall thickness, you can see here, even decreases because of the stretch. So, the wall stress goes up significantly. Now, cor pulmonale may have severe complications all the way up to death. Possible complications include abnormal heart rhythms, hypoxia, fatigue episodes, kidney disease, liver disease, and buildup of fluid in the lungs. Now let's take a look at left-sided cardiomyopathies, dilated cardiomyopathies. Normally, this is the consequence of increased afterload. What is afterload? Afterload is the amount of pressure that the left heart needs to exert to eject the blood during ventricular contraction. This is normally the systolic pressure. Now, let's assume for some reason we have aortic stenosis or constriction of the arteries or arterioles downstream. This means that this already high-pressure system offers even greater resistance. This is normally referred to as afterload, increased afterload. The consequences for the left ventricle are, here too, the blood starts to back up in the left ventricle. In addition, the left ventricle, due to much higher resistance here, will have to develop a much higher pressure than normal to counteract the increased afterload. Let's see which consequences this includes. Increased afterload and the effect on the pressure-volume loop. I discussed pressure-volume loop in a previous video. Here again quickly. We have here the start of diastole. We start to take up the volume until we get here. At this point, the ventricle starts to contract when all valves are closed. So isovolumetric or isovolumic contraction of the left ventricle. Normally, once we exceed the aortic pressure, the ventricle starts to eject the blood. And this is the stroke volume. Okay? Then the ventricle starts to relax again. However, if we have increased afterload here, increased resistance to flow, the consequences are as follows. Here again, the left ventricle starts to contract. We can see here, due to increased afterload, that the ventricle will have to develop a much higher pressure in order to exceed the aortic pressure. Then the aortic valve opens up. Then we start to eject the blood. We can also see that the ejected blood volume is much smaller as compared to the physiological state. This means that increased afterload results in decreased stroke volume and decreased ejection fraction from about 60 to 40. If this goes on pathophysiologically, this also leads to cardiac and cellular remodeling, and we can apply the same analogy as we had for the right-sided heart failure. I hope this was helpful.